Hello everyone, welcome back to CMME Easy, and I hope you all are doing very well. Before we begin, let me remind my dear students that the contents of this channel are only to supplement your knowledge, not to replace the regular online and offline classes in your institution. So please attend your classes and do not miss them. Also, if you like our contents, please subscribe to our YouTube channel, like the videos and share these videos with your friends, with your batchmates, with your juniors. Also, if you are a teacher, then with your students. Please follow our Facebook page and the link will be given in the description. In last few videos, we discussed few of the communicable diseases. So I think this is the best time that we take a little break from the infections and all, and maybe discuss something which I believe is not only important for the exam but also very important throughout our professional career. Because often we come across certain terminologies like screening of a disease, sensitivity of a test, specificity of a test. So all these things are related to the concept of screening. So that is why in today's video and as well as in next few videos we shall discuss different aspects and different important points which are relevant to screening. In concept of health and disease, there is something known as iceberg phenomenon. It is very important. Now we know about icebergs, which are basically big or huge chunk of ice floating in the sea. So what happens in an iceberg? The portion which floats above the level of water is much smaller compared to the portion which lies beneath the water level. Now this 1/10 or 9/10, these values may not be exact. It can be 1/11 or 10/11 maybe, but you understand, you get the gist, right? Similarly, in case of diseases, especially non-communicable diseases like diabetes, hypertension, etc., the people who have the sign symptoms are very less, and the people who have the disease but do not show any sign symptoms are much larger in number. So that is why these non-communicable diseases, only a few patients get diagnosed, and majority of them do not get diagnosed because they do not have any sign symptom, or maybe because of one reason or another they do not visit the doctors to get diagnosed. Similarly, in case of communicable diseases, sometimes what happens, even if a person gets infected and have the disease, they do not show any sign symptoms. These are known as inapparent or subclinical cases. Since they do not have any sign symptoms, they also do not get diagnosed. So here also a large number of cases of any communicable disease may not get diagnosed. So that is why we can see a clinician only diagnose or find out cases of disease which are very few in number as compared to the number of cases which remains undiagnosed or unnoticed. And it is the duty or role or job of an epidemiologist to try to find out all these cases which are undiagnosed or unnoticed, because these are subclinical cases, inapparent cases or undiagnosed cases. So as it says, a far larger proportion of disease is hidden from the view in the community than is evident to the physicians or to the general public. So when we apply screening test, we try to find out all these cases which are otherwise not diagnosed. Now coming to the definition of screening, different authors in different books have given different definitions, but more or less they mean the same thing. Here I have given two definitions. The first one, as given in the book of Park, the search for unrecognized disease or defect by means of rapidly applied tests, examinations or other procedures in apparently healthy individuals. The second definition is given by US Commission of Chronic Illness, and it says it is the presumptive identification of unrecognized disease or defect by application of tests or examination or other procedures which can be applied rapidly. So as you can see, these two definitions are more or less same. So what does it mean? So screening tests are basically some rapidly applied test or examinations or other procedures. So first thing that you have to understand is these tests should be easier to perform and they should be rapid. they are conducted on people who are apparently healthy. So these individuals who do not show any sign symptom, they would otherwise go unrecognized or undiagnosed. So that is why we apply the screening test in people who do not have any sign symptom. If they have sign symptom, of course they will be diagnosed. But if they do not show any sign symptom, they will go missed for the diagnosis. So that is why we apply screening test on the apparently healthy individuals. And also we try to find out the unrecognized disease or defect, because since there is no sign symptom, that is why these diseases can go unrecognized, and by screening we try to search or find these unrecognized cases. So this is the definition of screening. Another very commonly asked question is how to differentiate between screening test and diagnostic test. So there are certain points based on which we can see the differences between the two kinds of test. Screening test is done on apparently healthy people because they do not show any sign symptoms. So this diagnosis can be missed otherwise. Whereas diagnostic test is done on those with indications of sick. So since they are showing clinical features, they will be tested for the disease for the diagnosis. Applied in groups. So screening test in many national programs, there is provision of applying screening test in a group like high risk group. But this is not always correct. Remember this, screening test can also be applied on individual people. Diagnostic test is always applied to a single patient, right? A person coming with certain sign symptoms, the doctor is probably thinking about one particular disease, then he will go for the diagnostic test to confirm the diagnosis. The test results are arbitrary and final based on one criteria or cutoff point. So generally there is certain kind of cutoff value or criteria. If the cutoff point is crossed or reached, or the criteria is fulfilled, maybe we say that the person has screened positive for that disease. So this test results are arbitrary because screening test positive does not mean that the person has the disease. Similarly, screening test negative does not mean the person does not have the disease. So that is why this is arbitrary. The result can be arbitrary. It is not confirmatory. And this is the final. So either you say that the person has screened positive, or you say the person has screened negative. On the other hand, diagnosis is not final because sometimes one test is not adequate and you have to go for other tests to confirm the diagnosis. And modified in the light of new evidence, diagnosis is the sum of all evidences based on evaluation of number of sign symptoms and laboratory findings. So that means you can say for diagnosis we can do the clinical examination of a person, then ask about the history, then go for certain investigations, blood test, imaging, etc., etc. And based on all these tests and their finding, so based on all these evidences, we try to come to a diagnosis. Screening test is less accurate, less expensive, and not a basis for treatment, because what did I say? This is not accurate. So screening test does not always confirm that the person has the disease or not. So that is why treatment cannot be or should not be started based on the finding in the screening test. Whereas diagnostic test is more accurate, more expensive, and used as a basis of treatment. The initiative comes from the investigator or agency providing care in case of screening test. Whereas in diagnostic test, the initiative comes from a patient with complaint. This is understandable, right? A person who has the sign symptom, he will visit a doctor and he will be asked for certain diagnostic test. Whereas people who do not have any kind of clinical features, they do not know or they are not aware of their disease, of course they will not go to the doctor. So this is the responsibility of the investigator, the epidemiologist, or the agency who are providing care to try to find out if there is any disease present in this apparently healthy people. So this is the differences or differentiating points between the screening test and the diagnostic test. But we must understand that screening test and diagnostic test are not necessarily mutually exclusive. That means a single test can act as a screening test and also as a diagnostic test depending on the situation. Let me give you an example. Suppose a person attends to your clinic and as a part of routine investigation, you advise him for hemoglobin estimation. Probably the person does not have any pallor or any clinical feature related to anemia. Now the blood test report shows he has hemoglobin level of 9 gram percentage. So this confirms the diagnosis of anemia. So this is a diagnostic test because the person is diagnosed to have anemia. On the other hand, since the person did not have any clinical feature or sign symptom of anemia, and even then you try to find out anemia in that person, so you could say it was also a screening test. So that is why a single hemoglobin estimation test can act as a screening test as well as diagnostic test. The next concept, which is very important and also a very commonly asked viva question, short note, etc., is lead time. Here I have mentioned how a disease starts and progresses. The first point we have on the straight line is the disease onset. That means when the disease starts. The next point says first possible point. So maybe immediately after the disease has started, it may not be possible for us to diagnose the case. Okay, now let me tell you something here which is very important. This concept is mostly applicable for non-communicable diseases. That means all the chronic diseases which last for long period of time. So this is the first possible point. So that means at this point the disease can be diagnosed for the first time. Before this point there is no way we could diagnose the disease. After this we have the final critical diagnosis. That means when disease has crossed this point, there is certain permanent damage in the person at the cellular level or the tissue level or at the organ level, whatever. But beyond this point there will be permanent damage. So if we could diagnose the disease at the first possible point or anytime beyond that but before the final critical diagnosis, that means when there is no permanent damage, and if treatment or management is started, the disease will take a different course here, like towards the point B. If the diagnosis is done beyond the final critical diagnosis point, then it will take a different course, that is point A. Usually when we diagnose the cases, especially in case of diabetes, hypertension, by that time the patient has already crossed the final critical diagnosis point. That means there is already some permanent damage at the cellular level, at the tissue level or at the organ level. So this is why whenever we come across a patient of diabetes, the fact is probably the person had diabetes for last 5 years or even more. So by that time he will have some damages or some complications related to diabetes in his body. So that is why in case of type 2 diabetes, whenever a person is diagnosed, we send them to the ophthalmologist for the screening of diabetic retinopathy. So beyond this point, beyond the point of final critical diagnosis, we usually diagnose the cases. So what is lead time? Lead time is the usual time of diagnosis which is most commonly beyond or after the final critical diagnosis point and the first possible point. That means when the disease can be diagnosed for the first time. So this time gap between these 2 points is known as lead time. So if we apply different screening tests at regular interval, probably we can diagnose a disease at first possible point or immediately after that. So we don't have to wait until the usual time of diagnosis for the disease to be diagnosed. So that means the disease can be diagnosed at a very early stage even before the point of final critical diagnosis. And if we can diagnose the disease at early point, there will be no permanent damage at cellular level, and also if the treatment and the management can be started very fast or very soon, the disease will take a different course. So this is the concept of lead time. Now there are certain terminologies which are related to screening. First one is screening itself. We have already learned the definition: testing for infection or disease in populations or in individuals who are not seeking healthcare, because they do not have any sign symptom and they do not have any clinical feature. They will not visit the doctors, so they are not seeking healthcare. We just apply some kind of screening test to find out the disease in them, and they are apparently healthy. For example, serological testing of AIDS in blood donors, right? What about case finding? Use of clinical and or laboratory test to detect disease in individuals seeking healthcare for other reasons. So that means a person has come to the clinic or to the hospital for a certain disease. Maybe he is showing the symptoms of certain disease, but the person can be tested for some other unrelated disease as well if needed. In that case, it will be known as case finding. So the person is seeking healthcare but for some other reason. For example, the use of VDRL test to detect syphilis in pregnant women. So she has come to the hospital for pregnancy, right? Maybe for regular antenatal checkup, and we conduct the VDRL test to see if syphilis is there or not, so as to avoid congenital syphilis or even the problem in the mother. The next is diagnostic test. Use of clinical and or laboratory procedures to confirm or to refute the existence of a disease or true abnormality in patients with signs and symptoms presumed to be caused by the disease. For example, VDRL testing of patients with lesions suggestive of secondary syphilis. So maybe by screening test or maybe just by clinical examination, we are thinking about a particular disease, we are suspecting a particular disease. To confirm the suspicion or maybe to refute the suspicion, we have to go for the diagnostic test. So these are the three terminologies that we should understand: screening, case finding, and diagnostic test. Now, what are the different types of screening? The first one is the mass screening, where the screening of the whole population or a subgroup of population is done. For example, all adults screen for hypertension. So we may visit a village, maybe a health camp is done in a particular village, and all adults visit the village and we measure their blood pressure so as to find out the hypertensive patients. So this can be mentioned as a mass screening. The second one is the high risk or selective screening, which is applied selectively to high risk groups. For example, screening of cervical carcinoma in lower socioeconomic status. Another example is we could arrange the medical camp in a village and we invite all the elderly people, that means who are above 60 years of age, to get their blood pressure checked. So that is why we can say this is a high risk or selective screening, because the people above 60 years of age are at high risk of developing hypertension. There can be multiphasic screening also, which is application of two or more screening tests in combination to a large number of people at one time than to carry out separate screening tests for a single disease. For example, screening of undernourishment using clinical examination, anthropometry, and blood investigation among under 5 children. So to find out a single health problem, we are applying more than one screening test to a particular population. The example which is given here, if we are trying to screen undernourishment, we can go for clinical examinations, right? We can look for pallors or the nature of the skin, hair, etc. Anthropometry, as in we can measure the height, weight, then mid-upper arm circumference, and also go for the blood investigations like hemoglobin estimation. So all these things will give us an idea about undernourishment in the under 5 population. Now, what are the different uses of screening? It can be used for case detection, which is known as prescriptive screening, and also for control of diseases, which is known as prospective screening. In the next slide, we shall discuss prescriptive and prospective screening in details. Sometimes there are many diseases, the natural history of which are not very clear to us. So screening provides us opportunity for research into these diseases. With screening, we may come to know about the prevalence of the disease, the different clinical features of the disease, and that is why it is important in context of research. Also, all the informations that we can get from screening can be provided or can be given to the common people as health education for their own benefit. So that is why screening also provides us educational opportunity. Now, what are prescriptive screening and prospective screening? So when a person is screened and he is the one who is benefited out of it, it is known as prescriptive screening. While when a person is screened and other people are benefited out of it, then it is known as prospective screening. So screened for own benefit in case of prescriptive screening, while in prospective screening a person is screened for others' benefit. The purpose is case detection in case of prescriptive screening, whereas in prospective screening it is disease control. For example, if a person is found to have a disease after application of a screening test, it is a prescriptive screening because now the person knows that he has the disease and it actually benefits him. Whereas sometimes what happens in case of communicable diseases, when a person is diagnosed to have an infection or infective disease rather, then he can be sent to isolation, right? Or maybe some treatment can be initiated or whatever, and this will actually decrease the chance of infection spread to the other people. So that is why diagnosis or confirmation of the disease in this person leads to decreased transmission of the disease to the other. So other people are benefited out of it. So the disease can be controlled. The spread of disease can be controlled. So this is known as prospective screening. Who request? Generally, there is no specific request in case of prospective screening because the person does not know about his disease. Whereas sometimes some request from the authority can come in case of prospective disease. So maybe a person is screened for a disease as sent by the authority because the authority is concerned that if the person has the disease, he may spread the disease to others. Example is neonatal screening, pap smear done for cervical carcinoma, blood sugar, etc. So whenever these problems are diagnosed or confirmed, we can say this actually benefits the person undergoing the screening. On the other hand, screening for streptococcal infection, for rheumatic heart disease, immigrants being screened for tuberculosis, etc. So as you can see, if these infections are diagnosed, the people who are in close vicinity or in contact with the person who are being screened, they will be benefited, right? So these other people will be benefited, and that is why this is known as prospective screening. So in today's video, we learned what is screening and what are the different types of screening, different uses of screening, and also we learned the concept of lead time. So with this, we conclude the part 1 of screening. If you like the video, please subscribe to our channel and share this video with your batchmates, with your juniors, and also with your friends from other colleges. We also have our Facebook page that you can follow. The link is given in the description. Take care, and we shall see you in our next video.